All right, we're rolling.
Good morning. It is March 25th, 2025. My name is Deanna Diamore, and I'm calling the regular meeting of the Board of Health to order. Present, we have board members Frank Ehrlich, Anthony Santella, Norman Weinberger, and Ken Levine. And we should have Joe McNeil joining us soon. We also have Health Department staff members Aniela Fignon, Teresa Argandesi, and Megan Fogno, as well as myself. All right. The next item on the agenda is acceptance of minutes from the regular meeting of February 25th, 2025. Do I have a motion to accept the minutes?
So move.
Yes.
I think Norman, who was, do I have a second?
Yes.
Frank was the second. Any discussion on the minutes? Any edits, any suggested changes? All right. Hearing none, I'll call for a vote. All those in favor to pass the minutes, say aye.
Aye.
All right, that's 4 ayes. All right, thank you. All right, the next item on the agenda is public participation. Let me check. I don't see any attendees, so give another 10 seconds. All right, we will close public participation. David Reed, our medical director, has also joined us for the minutes. Good morning, David. Okay, so next on the agenda is epidemiology updates. Brian Weeks, our program director of epidemiology and informatics, isn't able to join us for the meeting today, but he did pre-record an update so that everyone could hear it. So bear with me as I try to make technology work.
All righty. Good morning, everybody. This is Brian coming to you virtually. Thank you, Deanna. Thank you, board. Thank you, everybody. We're going to be trying something a little bit different here because I am not able to make the morning meeting. And so, yeah, we're doing a recording. So this information is being presented on March 24th, Monday in the evening. So this should translate pretty well to what's going on here in this morning for the Board of Health meeting. So without further ado, we're going to do the usual presentation. We're going to focus on two things, the respiratory illness and measles situations, just getting some updates relative to that. So it will be a fairly simple presentation. And then, kind of some of the usual stuff that we're familiar with in terms of just respiratory prevention measures and things of that nature. So without further ado, looking at the CDC Respiratory Illnesses Data Channel, we're looking at it for the nation. You can see how we're experiencing low overall respiratory illness activity. And when you look at it from an emergency department visit situation, so again, that's showing severity of illness, you have flu at moderate, but then COVID-19 and RSV at low, all three experiencing decreasing trends, which is great. And then we look at the wastewater viral activity levels for the nation. Again, wastewater viral activity is an indicator and predictor of what's coming down the line, and then translate to the severe emergency department visits. We do see that COVID-19 and flu are still at moderate, RSV at low, so it still means we're getting through the season. But, it's a good indicator that, again, spring is here. It started on March 20th, and so definitely a vast improvement from how we were earlier in the year when we were experiencing more of the peak of the season, too. And so with that said, we're going to switch over to the state of Connecticut, and fortunately for overall respiratory illness activity as well as emergency department visits, we're mirroring the nation. But what is different here, and I want to highlight, is the wastewater viral activity levels. You can see here for COVID-19, we're still at high. We're low for flu, very low for RSV, so that's good. But, as I mentioned before, and as it seems like it's playing out for the season, again, we're getting through spring break, lots of travel, big changes in everybody's plans with the better weather, and so therefore it's giving more opportunity for COVID-19 to transmit, especially as flu numbers decrease. And so this is just something we need to be mindful of. Again, once more, still got to kind of get through the season, because, COVID-19 activity levels for especially the Northeast and Connecticut doesn't really peak until more March, if not April. And so we can kind of still see that play out in April time in terms of increased transmission and the aftermath of all these activities and things of that nature related to spring break. So that's just an important kind of factor to keep in mind. When we look at the NREVSS dashboard from the CDC, just to kind of monitor other respiratory illnesses, we're looking at the data for weekly percent of positive tests and this is for the nation. And you can see here on the right-hand side, the blue line, this is for influenza, and you can see that downward trend in which we peaked more or less in the beginning part of February. But what you do see here, outcompeting flu right now, is the rhinoviruses and enteroviruses. And so rhinoviruses are like more the common cold. Enteroviruses are a concern not only because they're a very large number of different enteroviruses, but some of them specifically resulted in a health alert network message from the CDC last year, in which certain strains can cause acute flaccid myelitis or AFM, especially in pediatric patients, which is more or less paralysis in certain parts of the body. And so it's something very important for parents to keep an eye on if they suspect their child experiencing any sort of abnormal functioning of their limbs, as well as any other kind of muscles in the body. But then also the providers also keeping an eye out for this so they can kind of test and treat this accordingly. But just keeping in mind that this is a rare condition, but nonetheless, it's something we want to be mindful of as, especially that activity increases. Then along with that, you can kind of see how the regular circulating human coronaviruses, so that excludes SARS-CoV-2, which is the virus that causes COVID-19, along with the RSV situation, and then the human metapneumovirus, the HMPV situation too, are kind of on similar levels. And so it's 'tis the season for all these, and so human metapneumovirus also kind of shows up later in the season, but something you want to just keep an eye on, especially that was the illness that was implicated in late November, December 2024 in China, causing some of those respiratory illness outbreaks that were created, some level of concern. But it is something that's normally circulating nationwide. And we want to just keep an eye on it, though, just to see how it plays out through the remainder of this respiratory illness season, because, again, it shows up later in the picture. And then all that activity is followed by SARS-CoV-2, which, again, causes COVID-19, adenoviruses, and parainfluenza viruses as well. And so with that said, again, all this kind of boils down to this really great infographic from the CDC, as, we are very well acquainted with. So just to summarize it real quick, keep in mind the immunizations for the viruses that the immunizations do exist for, and the eligibility, the hand hygiene, the respiratory etiquette, the opportunity for steps for cleaner air, so opening up the windows. Although I know I understand, again, springtime here, and we're contending with allergy season now. And so along with that, using air filtration where appropriate, but then in that case, making sure it's a MERV 13 or better filter. The treatments, so there are COVID influenza virals, but those should be taken as soon as possible. So following up with one's healthcare provider is very important, and getting tested to know and confirm which virus or other illness is kind of presenting itself. And then most importantly, again, as we get through this, especially addressing the COVID-19 bump and wastewater viral activity, staying home and preventing the spread, so that's waiting till one's symptoms are better without any sort of and they're fever-free without any sort of fever-reducing medications for 24 hours, and then following these following precautions for 5 days, which is the masks, the social distancing, and the rapid tests if you have them available. And if somebody should test positive for those rapid tests, then restarting this cycle once more, as very well acquainted. And so with that, I'm going to shift gears to measles really quick. So this is just a recap of kind of what's going on in 2025. So we have about 378 confirmed measles cases in 18 jurisdictions in the country, which also includes neighboring areas such as New Jersey, New York State, New York City, and Rhode Island. So this is not something that's, just located in certain parts of the country, although the epicenter, if you want to call it, for these outbreaks has been more Texas, New Mexico. It is spreading because there's pockets of opportunity, especially those that are not immunized against measles, that really kind of help contribute to the spread. And then along with that, as I mentioned, the travel and just all these other interactions and activity that can kind of help its geographic spread. And so, as we may recall with the last Board of Health meeting, we were only in the early hundreds with measles cases. Now we're at 378 just a month later relative to this update. And so the points to emphasize here is that about 3/4 or about 75% are 19 years of age and younger, so majority pediatric population, which then in turn means that just about, for 20 plus years of age, about 1/4 of individuals are presenting as cases. So you even have adults. And so that's just important that, again, everybody stay up to date and know their immunization status, and then take also the prevention measures needed, especially if they're higher risk. So again, that's, individuals experiencing pregnancy, immunocompromised, immunosuppressed state. Those are going to definitely contribute to greater risk if exposed. But nonetheless, with those individuals that have been presenting as cases, 95% are unvaccinated or their immune status is unknown. So this is, again, emphasizing the point to know your immune status along with making sure you're fully immunized. And, we'll go into that a little bit later. But then with those cases, about 17% have resulted in hospitalizations, right? Majority pediatric once more, but we have, a decent number that are still 20 plus years of age in that mix. So it's really important that individuals get the vaccine and the 2-dose series. And so that's something we'll emphasize a little bit later once more. Because again, there's also even the risk of death. So there have been 2 deaths associated with this outbreak in 2025. So far, 1 confirmed, 1 under investigation. And so we'll just jump over to the Norwalk Health Department's measles page. This has a lot of great information and infographics, just kind of explain some of the other risks related to measles, how to detect it, what to look for in terms of symptoms, and other information about the vaccine itself. Really important. Again, the vaccine is our best measure against this, and so if somebody does complete the 2-dose series and is given that 2-week plus window to develop that immunity, it is almost 97%, if not higher, in terms of effectiveness. So that's really, really phenomenal, and so it's really just great if everybody could just do that and make sure they're up to date with that in terms of the vaccines, and especially as their child becomes eligible for it relative to the CDC immunization schedule. That's really going to be a great measure to protect us, as well as maintaining, in terms of the Northeast and Connecticut and in our region, getting those levels as close as we can towards herd immunity, which is a very high number, generally speaking. But that will help kind of mitigate and allow if we do have measles exposure scenarios, for it to fizzle out, right? That's the most important thing, because measles is transmitting and throughout the world. It's endemic in certain areas, and it will make its way to the United States here and there. But then if you have high herd immunity, then it just fizzles out, which is what we want. Unfortunately, given, current circumstances, there are pockets throughout the country, even neighboring us and inside even the state of Connecticut, where individuals do not get the vaccines or complete it. And so therefore we don't have adequate protection and in turn, limited herd immunity. So again, just emphasizing the point that we want to do everything we can, and definitely from the health department standpoint, we're definitely doing everything we can, and a very good job, I might say, in terms of ensuring we try to stay up to date with those numbers relative to the MMR vaccine, as well as other vaccines too. And so again, if anybody does have any interest, we do offer the MMR vaccine here at our clinic at the health department. You're welcome to call the number here that's on the webpage at 203-854-7776. But yeah, just emphasizing these points. And so that's kind of the overall update about measles. It is still an ever and kind of rapidly evolving situation that will hopefully fizzle out, but we want to just do our part and do our best in terms of mitigating that. Then along with the respiratory illness situation, which is generally improving, but we need to get over this little hump related to spring break and just make sure that COVID doesn't really have an opportunity to really kind of grab hold and cause a big bump in terms of activity. So we still have a little bit of ways to get through that, and then naturally we're kind of contending with allergy season as well as other things too, that now entering with the better weather. But we'll take the better weather any day, right? So with that said, that is my update. Thank you again. Hopefully this recording approach worked okay. And appreciate it, everybody. Have a good day.
All right, and we're back. For the record, Joan McNeil, board member, joined at 8:11. And Joan, just so you know, that was a pre-recording of Brian giving an update because he couldn't make the meeting today. So thank you so much, Brian, for always going above and beyond to make sure everyone has the information that they need and the community has the information. Do any board members have any comments or any questions?
I have just a question, Deanna. In terms of measles vaccines in Norwalk, have you seen an increase of young people coming in for vaccines or people coming in for vaccines?
That's a great question. I can ask Darlene and get back to you. She hasn't shared anything with me that, we have per se, but that doesn't mean that isn't the case. So I can check with her and ask her. I don't know, Megan and Teresa, if you're aware of anything.
This is David. I was talking to Darlene yesterday, actually, and about the travel clinic and the vaccines we have. And we've had almost no people come to the travel clinic, and that's oftentimes where we vaccinate people who come in for these kinds of things. So that leaves the childhood vaccination program we're running, and I don't know what the status is of that.
Thanks, David. I think we're in a situation where it's great that we have such great immunization. You know, we have such great vaccination rates already. But I can also check with Darlene for more information. I do know that in general, our travel adult immunization, we're seeing some increased appointments for it, but I think that's related more to general travel, increased travel this time of year. Thanks, Norman, for the question. Any others? All right, I'm gonna pass it on to Aniela to present on the next two items. She's gonna give an update on performance management as well as quality improvement. And then Aniela, you can pause in between both, or you can go to the end and take questions at the end, however you prefer.
Sounds great. Thank you, Deanna. So I am going to hold questions until the end, but I'm also going to just get right into it so you won't have too long of a wait to ask your questions. All right. So today I'm just going to be doing a little overview and update on our performance management system, how things are going with that, and quality improvement, our entire program at the health department surrounding all of our continuous efforts to improve our programs and services. The things we'll talk about are just sort of a little refresher on performance management, a check-in on performance management measures, a little refresher on quality improvement, and some updates around our QI work, and then some next steps. So just as a refresher, our performance management system is meant to monitor the quality of performance of our public health processes, programs, interventions, and other activities, improve public health practice, and ultimately improve the health of Norwalk residents. We use an iterative strategic process where we set performance standards to improve or ensure maintenance of desired outcomes, measure our performance based on carefully crafted metrics, report progress on a quarterly basis, and we use this data to make improvements, sometimes with deliberate QI methods, sometimes with other methods. So the way that we have our performance management system set up, many of you are already familiar with this setup, but just a little refresher. Each division, our office in our department has its own dashboard where we set a goal for the overall division, and then we set a number of objectives. Each of those objectives is aligned with a domain. So as you can see, I'm focused on domain 1 here, which we call strategy and performance. And our objective is about informing and engaging stakeholders in the Norwalk Health Department's activity. We use a quarterly basis and a specific key to record all of our progress. And we set our measures for ourselves, our goals, right here in those domains. We then set targets for ourselves. So, we indicate the number of activities that we want to complete. We indicate the percentage of things that we want to have completed by a certain time. Sometimes it might just be that we want to end up with, one product at the end of the year. And so we're trying to set ourselves up and making sure that we're meeting that goal within a timeline that we would prefer. And then we have our status section where we kind of easily color code things for quick identification of whether we're in a good place or not so great place with our measures. And then we have the performance narrative section where we are able to delineate highs, lows, explanations really for how we ended up with the different outcomes, or if we ended up needing to tweak any of our performance measures. Sorry, I'm having a cat moment. I'm just going to get her off. We've been using this performance management system for a number of years now, almost a decade. But each year we iteratively refine it to make sure that the goals that we have set for each division are really in line with the work that we're doing in the current year, and also really speak to the things that we want to be achieving or the things that we hope to see in the community. So the way that we kind of gauge all of our success is to we use a little key, and we kind of score ourselves based on our progress using this key. So as you can see, dark green means that we've really hit the nail on the head. We've really met the measure. Light green is we're almost there, or we feel like we've done a decent job. and have pretty much met the metric. Yellow is, we really have a little bit of work to do here, but we're on our way. And then red is somewhere or an opportunity for improvement, an area that we really need to take a look at and potentially make some refinements. And then gray is usually an indicator that something has not been measured in the quarter. There was not a specific goal in mind. We might have just been tracking the number to get a baseline kind of for a potential future measure, or the data was insufficient. For example, sometimes data for some programs like WIC takes a little while to come in because we're waiting on the state for those reports. So, you'll see a couple of grays here, but by the end of the year, that gray section will really become a much slimmer portion of the pie. So as you guys can see, we have 76 measures that we are taking a look at this year. It's a much lower number than the 100 and something that we had last year. So it's been, a little bit easier to track, but still lots of work. We're primarily in the dark green or the success part of the pie, which is great. And a lot of the measures where we are, almost there, or, maybe we're not quite there, or we have a little bit more work to do. The only reason that a lot of those are really, they're not that perfect dark green is because we have, the rest of the year to continue to meet these goals. So obviously, in order to get the total number of measures and to see where we are as an entire department, we track each of the divisions to identify how they're doing with each of their measures, and we give them a little bit of an overview on a quarterly basis. So as you can see, we have each division here, from administration all the way through preventable diseases, and it's really easy for them to take a look and see, oh, okay, like this is maybe a year or a quarter where we didn't do as well as we might have hoped, or maybe things didn't turn out the way that we might have hoped. A lot of times the things that affect these outcomes are really out of our control. There are things like capacity issues, the outcome measures where we can't necessarily control the outcome of the metrics. The reason that we maintain this performance management system, other than monitoring ourselves and ensuring that we are doing the work that we say we want to do, is really to ensure performance. So as you guys are probably familiar with, we have this performance management system graphic that describes how we developed objectives and measures. We carry out those activities to meet objectives and targets. We track all of those activities on a quarterly basis and report the progress. We do an annual analysis, which you guys usually get every October, with results of the dashboards, identification of opportunities for improvement, and next steps of how we want to improve things. During that time, we also take the opportunity to identify potential quality improvement projects, and then we evaluate and modify the system as needed. So making those tweaks and heading into the next year. The relationship between performance management and QI is very simple, and yet also very, very complex in the sense that really one cannot exist without the other. So performance management is the systematic process of using data to make decisions. That data is used to measure, monitor, and communicate progress towards intended outcomes. And then quality improvement, or QI, tools are used to overcome barriers to progress. So it really is this sort of cyclical process where we're taking a look at our performance, we're seeing where we can improve, we're prioritizing those improvement opportunities, putting them into action, and then seeing how that affects our health department. So moving into quality improvement, which is that sort of second part of performance management. Quick refresher that QI in public health is the use of a deliberate and defined improvement process, which is focused on activities that are responsive to community needs and improving population health. It refers to a continuous and ongoing effort to achieve measurable improvements. That's the keywords right there. And efficiency, effectiveness, performance, accountability, outcomes, and other indicators of quality and services or processes that achieve equity and improve the health of the community. The way that we gauge, how QI we are at our health department is to assess our culture of quality improvement. Now, NACHO, which is the National Association of City and County Health Officials, has put together this nice little roadmap where you can get a sense of where on the spectrum we are in terms of integrating integrating the culture of quality into our department. Phase 1 being sort of that no knowledge, it's really not part of our department. Phase 6 being, it is really truly something that everybody in the department feels empowered to do and really feels confident leading. And we use 6 foundational elements to sort of assess whether or not we have, hit the mark in terms of, being closer to that right side of the spectrum where we're, doing QI on a regular basis. So there's leadership, the QI infrastructure, which is our performance management system, as I mentioned, the QI plan, which we presented to you guys last year, and our QI work group, which meets on a quarterly basis to discuss QI project proposals, updates to QI projects. We do QI trainings to provide intermediate sort of training to that QI work group so that they can be champions. We really focus on employee empowerment, so making sure that the knowledge that we learn in our QI work group is really spread throughout the department, right? So we are supposed to be champions of quality improvement and really bring the tools and the information and the lessons that we learn at our work group to the rest of the department and make sure that everybody feels empowered to be doing QI in their own day-to-day work. We also maintain a strong customer focus. So that means that we are always thinking about our external and internal customers. So that's, our clients, the people who we serve, and then our stakeholders internally. So our staff members, our Board of Health members, the city that we serve, we're always thinking about everybody who's involved in each process. We have a strong focus on teamwork and collaboration, as any successful and healthy department probably should. We really make sure that our work group is comprised of people, staff members from across all of the divisions and from different levels of work. So we have entry-level folks, frontline workers, we have program managers who are involved, and we also have senior leadership who's involved. So it's a nice mix of people, and it means that we are able to address, projects in a more holistic way. And then the last element is continuous quality improvement, which means that we are, dedicated to making those small iterative refinements on a regular basis and not making QI something that's a static operation where we get into our work group and we talk about QI and then we leave the work group and QI is left at the table. No, it's something that we really make sure is incorporated into our day-to-day work. So what have we been doing that is quality improvement related at the health department over the last year or so? Well, I'm going to talk a little bit about our culture of quality, and then I'll give a little bit of information about the projects we've been working on. So in terms of our culture of quality, we have a work plan in place that guides a lot of the things that a lot of the activities that we like to maintain or push forward. So what we've been seeing over the last year is that leadership and staff from across the department have been engaged in all QI activities, which is great. We've had training that's been delivered both to frontline and program manager and senior leadership staff, as well as a couple of folks, myself included, who are getting a little bit more intensive QI training. We revised the quality improvement plan, which was a big overhaul. It was really exciting to take on with our entirely new work group. It was their first time going through that plan. We also make sure that we, monitor our performance management system and keep that going. So we complete an annual analysis every year. We refine the system as needed, and we monitor the system throughout the year. So if tweaks are needed to the language of a measure so that we can more appropriately measure the activity that we are looking at, those things all happen on a regular basis. So again, that continuous QI. Our QI work group, which again meets on a quarterly basis, recommits annually each year in December. So this past December, we were able to get everyone to recommit, which was really exciting. It shows that we have a really dedicated work group who is very interested in QI. And we also have a ton of people who are always telling us that they're interested in joining the work group. And so we're trying to figure out ways to make that more accessible to them, because I know that everybody's workload and capacity is a bit limited. The last thing that we do is, again, we have those continuous quality improvement assurances by having those work group meetings and by having QI project team meetings. So anytime that a QI project is initiated, there's a team that's assembled, and they are all briefed sort of on the purpose of the project. Everybody gets to have their voice heard. The project is refined to reflect everybody's thoughts. And they meet regularly to ensure that everybody is really involved in the project. Over the past year, we were really excited to wrap up 2 big projects. So the first was our flu clinic QI project, which was really quite a bear to take on. I want to do a little shout out to Kelly Tomlinson. She's our health educator, and she led us through this project. She did an amazing job as the team lead. But we were taking a look at 2 things surrounding our community flu clinics. So the first thing that we wanted to assess were communication strategies that we use to promote and advertise our seasonal flu clinics. So what we did was we invested in a ton of different communication strategies. Some of them were free, some of them were low cost, like social media posts. Some of them were, costly. So the bus wraps, billboards, things like that, that might, attract a larger audience or reach a larger audience. And we were really surprised with the outcomes to find that, a lot of the times when we use some of those free or low cost advertising methods, those are the methods that really garner attendance at our clinics. So it was great to kind of get that information because it'll be so helpful in informing our future flu clinics and all of the advertising and promotion that we do around it. And then the other part of this project, so this was, again, a big project and had 2 prongs, was developing a standard operating procedure. So going into the project, we knew that we needed some more consistency in each of the clinics because we have different types of clinics. Some are community clinics where we have a bunch of clients come in, within a short period of time. We have our regular in-house clinics where during regular working hours, people are able to make appointments. And then there are also worksite clinics, where we sometimes go off-site to work directly with organizations and provide vaccinations to their staff members. So each of these kinds of clinics has a slightly different flow, although they're all pretty similar. And so there was some confusion because we would kind of switch back and forth between models. And so the point of this particular QI project was to come up with a standard operating procedure that would be consistently applied in every kind of clinic. And we were successful in developing that standard operating procedure. It took a lot of work. It took a lot of refinements, going back to the drawing board, figuring out where the kinks in the process were and eliminating those. But we feel confident that this will be very, very helpful going forward into our next flu season. The second project that we worked on was a grants filing system. So just a little background on this. The staff members at the health department have always done a great job of maintaining their grant files, but it's typically been in an inconsistent way where whoever is responsible for maintaining the grant or managing the grant has had their own sort of landing place for any documentation related to it. What we found was that it would be much more accessible and easy for staff to have one particular landing place for us to go and access all grant documentation. And when I say all grant documentation, I mean all of the formal things. So, the final proposal, the program reports, financial reports, contracts, things like that. Not all of the little kind of like pieces of programmatic activities that you might work on for a grant. And so we wanted the system so that if someone were out of the building or not available and we immediately needed to pull some information related to a grant, it would be super easy for us to do that. So we developed a standardized grant filing system where there's a standardized set of folders in each of the grants, umbrella folders, that is replicable across each of the grants. and can be used as needed. So some grants may not, need to keep all of their meeting notes in this folder. But really, it's a place for all of the formal documentation to land, anything that's relevant for anybody else who might want to be apprised about the status of the grant, a landing place for them to go and get that information. The other thing that came out of that was a staff training. So we wanted to make sure that if a staff member was unclear on how to use the system, that they'd be able to quickly access a PowerPoint training and walk themselves through. So there is now a training in place that all staff are able to access and review at their leisure. Next steps at the health department. So in terms of culture of quality, we're going to continue to deliver basic QI training to new staff members. This is something we do on a regular basis. Actually just gave a training 2 weeks ago, and I'll be giving another training in another week or so. But this is to ensure that everybody has some basic knowledge of quality improvement, and that we really do have that department-wide understanding of the importance of QI. Our Director of Health, Deanna, is also going to be delivering a training on the Kaizen QI philosophy, which is all about small incremental changes that can build up over time to have great and impactful outcomes. The idea is that we want to engage the QI work group at annual analysis to identify improvement opportunities using this Kaizen technique. So what are some of the small refinements that we might be able to make looking at our dashboards and heading into the next year that might be helpful for either improving outcomes or improving the clarity of a measure? We're also hoping to seek a consultant to deliver public health focused coaching or training to our QI work group. So this is something we've been thinking about for a while. The purpose is really to cultivate confidence in our QI work group members to propose, lead, and navigate QI projects. So as I mentioned, as I may have mentioned in the past, actually, we sort of reinvigorated the QI work group in early 2023 after the pandemic had slowed down a bit. And so a lot of our work group members, myself included, are somewhat new to the QI world. And so we really want to make sure that all of our QI champions feel equipped and ready to lead QI projects and to make sure that it's a part of our culture. We want to make sure that people are confident. In terms of projects, we will be looking or considering rapid cycles of smaller projects related to the flu clinic. So, taking any additional kinks that we identified during our flu planning process and doing a small rapid cycle on that. There was also a project that had been proposed in the last year that was all around awareness of health department happenings and ensuring that staff members were apprised and aware of events that were happening throughout the department. What was really nice to see was that because this was on everybody's mind after having this QI project proposal, we actually saw that it was organically addressed through other means when we created the staff newsletter. And so I really want to thank Kelly Tomlinson and Catalina Mosquera for pushing that work forward and making our department much more connected and engaged. So I'm appreciative of the fact that we really do have a culture of QIing here at our department. And then the last thing that I want to mention is that we have a project proposal on the table that we are going to be taking a look at related to IT asset tracking. So this is a project that affects the entire department, or a proposed project rather, where we are considering having an additional sort of backup system for tracking all of our technical equipment to make sure that we know, like, okay, where did our grant funded, laptops end up? Where, how old is this particular laptop and do we need to replace it? All that kind of stuff. So it would just be, an additional check and balance for us at the health department to maintain all of that equipment. And that is all. There's lots of QI stuff that's always going on, but those are the big highlights. So please let me know if anybody has any questions.
I had a quick one. And when we're doing the measurement of the different projects that we have and we're measuring and saying we're, let's say 75% completed, is the measure that we're doing is a measure against what could be done or what has not been done when it could have been done? Do you understand? Does that make sense?
Sure. So I think, are you talking about performance management, like over here?
In general, yeah, something like
Okay.
that. So they were saying that 58% is in the green. Is there anything
Yep.
in the purple and the red that could have been done? If it could have been done, then we should measure against that. If it hasn't been able to be done, trying to use it as a denominator will only hurt our percentages. I just wondered if we look at what hasn't been done because it's not supposed to be done yet.
That is a great question, Ken. And actually, Deanna and I were just talking about this yesterday. So we shuffled some of this around because we didn't want some of those denominators to be skewed by activities that we had no control over. So for example, in the community health division, Teresa has been really ambitious with setting out some community health measures with metrics. So that would be, outcomes that we see in the community. Which is amazing, to be able to track, but sometimes out of our control. And so we did end up shifting some of those numbers to reflect that the work has been done, and that there are some areas where we're not able to control the actual outcome.
Thank you.
You're welcome.
I'll just add to, we had a goal to, for preparedness, to attend X amount of meetings and, because they hadn't been scheduled yet, I asked Daniela to change, like they had been canceled, by our regional partners. So, let's not ding ourselves on that because we physically couldn't be there. So, and also we've thought about, just to add to anything else saying about the community health, it's interesting. So like it's standard for reportable diseases when you're doing follow-up with somebody, you're trying to find somebody who has a reportable disease. You tend to call 3 times, right? So you try once, you try twice, you try 3 times. If you can't reach them by the 3rd time, you've met your metric of reaching out. For the more serious matters, of course, you're going to do more additional follow-up, but in terms of some of Teresa's, follow up with the know your numbers, the people that go through that program, sometimes it can be hard. I think we've talked about this in the past. It can be hard to reach some people. They can change their phone numbers. But Teresa's are like, you're going to reach them, at 100%, that's her goal. Like she's going to reach everybody. So we've talked about, maybe we need to look at some of that too, to give them some leeway and think about it to the point of like, well, there could be a measure of like, how many phone calls they attempted versus how many, they're able to reach, like follow both of those. Thanks, Ken, for the question.
Also, with your new potential project, I think your accounting department will love someone to do an asset management program to get all that stuff into the grand list.
Oh yeah, this is definitely going to be a project that affects nearly all of our divisions. So I know our supervisors and staff, quite frankly, are pretty excited to get this one started.
My question was also on the same slide that you were, the objective summary slide. Yeah, that one. Can you talk, if you're able to, briefly about the 6 grays under administration and the 4 reds under environmental health? Just a sense of what those are.
Absolutely. So I'll start with administration. So in terms of administration, we're actually a little bit further ahead than the data reflects. We're really behind on data reporting. We're up to date with our fee setting. We're up to date with our, we're in the process, of updating our fees. We're up to date with our programmatic and financial reports. And then 2 of the 6 measures were related to work at the reception front desk. And we had an employee who was in training for the first 2 quarters. And so we did not measure that work because it was an additional burden on her while she was trying to learn the basics.
What does that mean? Like something that the receptionist does is a measure. And so
yes,
if she was learning how to do it, you didn't want to measure her while she was training for it?
Exactly. So those 2 measures, they're about, getting in touch with clients in advance of their appointments. And there's a lot of data collection or data recording really that's needed to do that. And so it just seemed like it was a little bit too much given that she had started at the end of June and had so many other things to be recording. And so we thought that, or rather knew that we would end up getting skewed data because it wouldn't be consistently recorded. And so that's how we ended up deciding to just, pin it for the first 2 quarters.
Mm-hmm. And what about the environmental health?
Yep. So environmental health, we had a different kind of thing. So as you all may know, we have been looking for a health inspector to support the environmental health division. And so the two areas where we're really falling a bit behind is food inspections. We're pretty far behind on that, and Deanna has been very clear about that with our BET. And letting people know that, the more mandates or requirements and inspections that kind of get put on the department, the harder it is for us to meet all of the different requirements. And then the second area where we have, not met our targets consistently, are salon inspections. And this is in large part due to the fact that we've had to increase the number of salon inspections in the wake of some, reasons for the need for additional inspections. Does that answer your question?
Yeah, so it seems like it's kind of being driven by increased mandate and staffing that can't keep up with the increased mandate, which kind of goes to the point made earlier about things out of your control when you're relying on city budgets and other things to support the mandates. Is that basically the gist of it? Yeah.
Exactly. And so we do include this in our performance narratives, and we almost every year in recent years, we've been a little in the red for food inspections and salons. And so we've included that and just, been very clear that if we had more capacity, we would probably be able to meet these measures more easily.
I'd also just like to add that, it's for sure a matter of, vacancies and budget driven, but it's also, there's larger issues. And I was going to talk about this during my updates. Just statewide, it's really difficult to find staff members that have all the certifications and that have all the trainings in place. We thankfully now have our Kevin Closer serving as our food inspection training officer. It took us, probably 2 years from the state to get one locally trained here. So now we're going to be able to train our own staff to be able to be certified. And the state made some changes to make it easier for locals to do their own certifications. And that was a lot of advocacy done by the health directors across the state and the Connecticut Environmental Health Association as well. So there's a lot of good news in that end. And I think we'll be able to hopefully, see some of these numbers improving as we're able to fill more of the vacancies.
And I see a lot of that on my end as an educator. I see those postings come through to us, for the sanitation inspector roles. And 9 times out of 10, I can't really share them with our students or alumni because of, to your point, like the qualifications are so specific that no MPH student or recent grad would have those. And I know Southern was partnering with the DPH to offer kind of a training course, but it's in the middle of the workday. So when you think about the people who are working and going to school aren't going to take time off their paid job to go do this training that may or may not lead to a job. So I always scratch my head about that one because I see a lot of those jobs and they just seem to kind of, I don't know, go unfilled for long periods of time.
Correct. And so I know there's a lot of effort at the state level to try to make, it easier for health departments to do their own training and support the certifications. I know, all right, I'm going to spoiler, this is one of my updates with staffing is, we had a sanitarian position vacant because we had a retirement, and that requires the RS licensure and certification. It's a very challenging exam to pass. And so it's harder. People are stealing people from each other, right? In different departments, they're moving around. And so we're going to be posting that position as a health inspector instead. So the qualifications are not as great. And so the point is that we'll be able to, develop our own internal workforce, be able to bring somebody in, who has fewer qualifications, but can gain them over time.
Deanna,
Mm-hmm.
is there any effort at the state level the only word that comes to my mind is coordinate, but if Stamford had worked out a solution to one of these issues that are on the screen, is there any effort at the state level to demonstrate data that would help communities that are not at the upper level and how to get there.
Frank, can you give a little more context to the question? Are you talking specifically environmental health or just in general, like
I'm
performance
talking just
measures?
in general. For example, Anthony's comments bring to mind that are the criteria for a position appropriate if another community had solved it using different criteria? There's an opportunity for the state to present data to all the communities and perhaps gain some advanced knowledge as to our criteria are too strict or they're not strict enough.
Thank you, Frank. That's a great question. So I do know that, the commissioner has semi-annual meetings with health directors, and they offer an opportunity for health departments to share amongst each other. So there have been some highlights related to workforce development and work specifically in environmental health, and how some departments have been able to hire people and get them trained up and in the workforce. So there has been some of that sharing. I don't know if it's a comprehensive, analysis and reporting and, looking at every department, but I do know there is that effort to look for some of those best practices and making sure that they're shared amongst the health departments.
Okay.
And I do know that, there was from the local level and the state recognizing, lower capacity levels for both, and figuring out what we can do to help each other and to ensure that we have the right people in place to be able to do the important work. And so there are conversations amongst locals and the state health department, and that's why you see some of those changes where now locals, if they have a food inspection training officer, they're able to train and certify their own staff and not have to have the state do it. So it's like the train the trainer model. The state trains the trainers, and then we can then train our staff.
Okay.
Thanks, Danielle, for a great presentation, and thank you all for great questions. Anything else? All right, I know we're coming up at 9 o'clock soon, but so my updates for staffing, I was going to mention the whole health inspector versus a sanitarian, so we'll be posting that position soon. That position had been vacant because I mentioned the retirement, and then there was a hiring freeze because of budget issues. And so when we were finally able to post it again, we didn't get anybody who met all the qualifications apply. So that's why we're doing the health inspector. We also have, as you know, we have our suicide prevention grant. So we've been able to bring on Brianna, who is helping us in that program, helping Kelly and Teresa, who are leading those efforts. So she's been great. And then we've had Maria join us, who's a data analyst, working with Brian to help him do additional support and work. Those are some of the staffing updates. And then as far as director's report, the budget, we had the meetings with the BET that went well. There were questions about, the public health nurse. If you remember, that's one of the positions that I requested in the budget, and that had been recommended by the mayor and the CFO. And so there were just some questions about that, and I was able to really speak to the importance of having that additional support in the health department. And so that goes well, so that there's going to be a public hearing soon for the budget. I believe it's tomorrow night. So that continues. But the mayor really spoke on the positions that he recommended were really only the ones that were crucial and needed in terms of the new positions that were added. National Public Health Week is coming up. It's the week of April 7th, so stay tuned. You'll be getting some information from us on it, and we might be doing some events, and we want to invite you all to them. So we will keep you posted on that. just trying to get the word out about the importance of public health and health departments in their communities. We also have some other just awareness events coming up in April. We have National Infant Immunization Week that occurs April 21st to the 25th. That will highlight the importance of all newborns and young children receiving their age-appropriate immunizations on time. And then there's also Adolescent Immunization Awareness Week that also falls April 7th to 11th to promote vaccinations for preteens and teens. Related to immunizations, our IAP program continues to do amazing work. We've completed flu and U presentations at local early learning centers and elementary schools in the Norwalk and Danbury areas, visited 16 programs and schools and engaged with 676 children. So great work there to Pam and Sarah and the team. There's been some great updates with WIC too. Now that they're fully staffed, they've been able to do more outreach into the community to get enrollment numbers up. They've seen an increase in enrollment with first trimester enrollment by partnering with different community organizations, local medical providers, Head Start, Norwalk Hospital, to be able to speak to community members and to providers about enrollment. And then also there's been a partnership with Bridging the Gap Project with Connecticut Children's Medical Center and the WIC program in the regions to support families. And so it's connecting children who could benefit from additional development support and services. And so there's, with the Birth to 3 program, so there's also been a great partnership. So I just wanted to highlight some of that. And then lastly, I'll just say that our reaccreditation annual report is due at the end of the month. And so staff have done a phenomenal job. Thank you, Aniela, for leading us and for all the staff that have been working on it. We're highlighting some of the measures and the progress that have been made. And we're also, we've completed an assessment of all the different standards and measures for the next round of reaccreditation to see, what do we have for documentation and what do we need to still develop. So that was a big effort by the team. So I just want to thank them. Any other questions before we wrap up?
Any other news from the statewide grants and opportunities with all the mess going on in DC?
So they keep us up to date. It seems like, always getting new updates, every day. We heard from the state about, if you have guidance related to if you have an executed contract, if expectations are that, you're going to still complete the activities, keep moving forward. If there's any other changes to reimbursement that they hear, they'll follow up with us on that. And we did get some hopeful news that, we were going to get additional funding for some of our immunization work that would take us through the end of June to be able to support some COVID-19 outreach and other immunization outreach. We had been told that, if we hadn't had if the amendment hadn't been executed, it wouldn't be guaranteed. But then a couple of days later, I got the executed agreement that for the mayor to sign it. So that was good news to see. So hopefully that will fall through and we'll be able to sign that.
To follow up on Ken's question, is there any plan or effort underway to prepare for the worst situation? Mainly because Connecticut is a blue state, and looking at things that are going on nationwide, blue states have taken it on the chin. When somebody has to take it, it's a blue state. And without making this a political discussion, are you ready for significant changes in financial support?
So I will say that because of Mayor Rilling, because of the Common Council, the BET, and the Board of Health, I think that we are in a better position than some to be able to withstand some of this because we've been able to add capacity over several years. There are several health departments that had epidemiologists that were on grants, and I don't know if they're going to be continued after the grant ends or not, but we have our program director of Epi and informatics on the operating budget. We we're advocating for that additional public health nurse so we don't lose that position. And so that's still moving through the budget as of now. We've added additional community health support. We've added additional administrative support. So there's been efforts over several years to sort of build back some of what had been lost over the years with other economic downturns. So I think we're in a good place as of now. And there's always the risk of, what's to come. But I know our team we've dealt with a lot, especially the past 5 years. So I'm confident in our team, and we'll do what we can to handle whatever comes next.
Thank you.
All right. Hearing no other questions, discussions, motion to adjourn, 9 a.m.
Motion to adjourn.
All right. So moved. I see everyone saying yes. Okay. Thank you, everyone. Have a great day.
Thank you.